We got a question earlier this week from a patient that was asking about endarterectomies. I know this is quite the jump, but I wanted to make sure that we get in
Okay.
some of the questions before we're short on time today for this one. But endarterectomies, the doctor went in and had a failed angiogram. The common femoral artery was too far blocked, couldn't get a wire through. And so the doctor said, next step is an endarterectomy. So he wants to know, what is an endarterectomy? What can he expect? Any complications he should be aware of, and critical questions to ask his doctor before going into the procedure.
Okay, fantastic. This is a great question. So at the level of the groin, we have the common femoral artery at the level of the groin. And this artery does not respond very well to treatments that are endovascular. The big one is a stent. We cannot stent this artery. As vascular surgeons, this is a big no-no, just because the data on doing an endarterectomy, and I'll explain what it is so robust and still great. An endarterectomy is where you make an incision with the patient completely asleep. This is a hospital-based procedure. You cannot do this in the office or in a surgery center. With the patient completely asleep, we make a longitudinal incision in the groin. And what we're going to do is we're going to open up that femoral artery. And in the process of opening up that femoral artery, we use a series of, they look like small spoons, small knives. We're going to scoop out all of that plaque of that artery, all of it. And by doing so, we're going to basically open up that artery, get all the plaque out, and instead of suturing it back together again, we're going to put a big fat patch on top of it. That's the patch angioplasty that we put on top of the artery. And the reason why we do it is because everybody scars. Everybody scars. So if I make it almost double in size and it scars over the next 10 years, it's going to go back down to the same size it was initially. Making it bigger actually helps that patient get significant resolution. Procedure takes about 1 to 2 hours to do. There is a backup in case that endarterectomy is too extensive. You're like, oh my goodness, I've got plaque from the iliac artery down into the profunda, down into the femoral artery. What am I going to do here? This is very difficult. In which, as vascular surgeons, we also have to be trained in doing a bypass, where we're like, you know what? I'm going to abandon an endarterectomy. This is too extensive. And I'm going to connect the iliac artery to the femoral artery and the profunda. It's a bigger operation, but still takes about 1 to 2 hours. The majority of patients spend one night in the hospital. Majority of patients. Um, on my patients, I prescribe them with narcotics. Majority of don't even need it because I try to make small incisions. And then over the next 4 to 6 weeks, what can they expect? Well, the biggest one is a lot of times that calf pain and foot pain already gets better. This is the main artery going down their leg. Second thing that can happen, and happens, I would say, in about half of patients, is they end up with a swollen foot. And they're going to say, Doc, you did the surgery to me, and now I have a swollen foot. And that's because there's a lot more blood flow going down. And because there's a lot more blood flow going down, those veins aren't ready to send all that blood flow back up yet. So you end up with a swollen foot, and that is normal. It goes away in about 4 to 6 weeks. And for that, the treatment is elevate the leg and walk. And now that you can walk, we absolutely are going to encourage it. Absolutely. The biggest complication that we can get from a femoral endarterectomy is an infection. That is the number one complication. Now, it is a very slow number. It is a very small number. We're talking less than 5 to maybe 7%, because you're in the groin. And in the groin, it's a nidus for all types of bacteria and yeast that can be there. And that's the biggest risk that you can have. In a groin incision that gets infected, they're very difficult to treat. Sometimes it does require a prolonged hospital stay. That's where we do debridements, where we have to clean it up, maybe put on a wound vac. But that's the biggest complication. And then the failure rate, in which you do an endarterectomy and you know what, it didn't work, is less than 10% at 8 years. And that is one of the biggest series for endarterectomies, which, if you look at that data, that's really impressive for vascular surgery data.
You mentioned the potential for bypass, and
Yes.
when a patient goes in for the endarterectomy, should they be prepared for a potential bypass? And just in case, even if the doctor doesn't talk about it, should they ask the doctor, hey, what happens if you go in there and it's a little bit more robust plaque than you realize? Like, what is the contingency plan?
Yes, that's absolutely a question that you have to ask your vascular surgeon. What if, just like you said, what if you go in there This happened to me yesterday during an endarterectomy. I had to use a patch, and then I had to open up a second patch and use half of that one because there was just so much disease. But what happens if you go in there and maybe somebody already did an endarterectomy, or they had some type of atherectomy angioplasty and the damage was so extensive that you cannot repair this artery? You have to ask your surgeon, what is your backup? And if this doesn't work, what is your backup? Well, if you can't connect it to the femoral artery, how are we going to fix it? I would say for vascular surgeons, we also always have to tell patients there is that possibility that we might have to do a bypass. Now, the risk is very low, but you have to have the conversation.
And in those types of bypasses, in those situations, usually when you have a patient and you say, okay, we're going to prepare for bypass, they do vein mapping and they talk about using, your own vein, right, for that.
Yes.
What happens in those situations, such as, you said even with a recent patient of yours, what happens if you end up with a bypass and you didn't do all of that prior to? What is the direction you go with this bypass?
Um, that's tricky because that's part of the due diligence. You have to be, be ready for the worst every time you go in there. It's part of the job. There's always, if you didn't do vein mapping, there's always that possibility that you could explore the vein, make an incision and make a dissection and see what you can find. And I will say the majority of the time, we do find suitable veins. But what happens if that patient already had open heart surgery and that was the leg that they took the vein from? Now, what are you going to do? Are you going to risk the other leg by taking that vein, or are you going to use a piece of plastic for a bypass? All of these are those contingencies that you had to be ready before you took that patient to surgery.